We'll be talking about the core model today, and we'll be walking through that. My name is Keith Khunpha. I'm the technical lead for the program, and I'll be speaking with David Ianson, who is Cancer Commissioning Manager. Just a very quick talk about the core model itself. This basically looks at high volume, low complexity cases. Typically, they're quite kind of what we call, quote, simple processes. So there's not lots of multiple branching pathways coming out of it, for example. And we're looking at typically just the next 52 weeks. So this is a relatively operational type of tool that's used to help support your day-to-day planning effectively. Because it's looking at relatively straightforward processes, it's a good starting point for anyone who's new to modeling. So sometimes when you're looking at demand and capacity modeling, folks are kind of like, where do I start? This is a pretty good place, especially because by its very definition, you're looking at a relatively simple process. So hopefully it'll be something that you can get to grips with quite easily. The way we use these models is we've designed them to be quite generic. So previously there were a number of tools developed they were called the IMAS tools. They were developed by the Electric Care Improvement Support Team, and they covered, I think, 6 different types of interventions. So you had, for example, diagnostics, you had inpatients, you had 2-week wait services, and all sorts of things like that. Basically, we've combined them into one thing for the core model. So basically, the idea is that you can customize the core model, and through exploring the different options, you can then gain a bit of insight into your own service, as well as make the model actually fit for modeling your service itself. And in terms of what it does, it basically tells you if you have the right capacity to meet your incoming demand and whether or not you can expect your waiting list to rise or fall over time. And secondly, it will look at your waiting list size and see if it's within a sustainable range to support delivery of your access targets. So for example, if you need to see your patients within, say, 6 weeks, whether or not that you're likely to achieve that given the size of the waiting list that you have.
And Keith, so just before we jump on there, I think one of you kind of touched on this, is a benefit of the core model compared to the other models that you'll see available. So especially around, some of the more diagnostic tools that are available. The core model is really good because it has that flexibility and it allows you to go into more detail on certain things, and it is that customizable side of it that is so beneficial. So when I've done stuff on endoscopy, and we've looked at using the endoscopy tool that's also available, but that's actually relatively restrictive in terms of looking at subtypes of colonoscopies or upper GIs. So the more therapeutic procedures, which capacity is managed very differently between those therapeutic procedures and those more bog standard diagnostic ones. So the core model allows you to be really flexible and contain all of that detail all in one place, and it makes much more sense to a service when you're capturing that level of detail, because that's how they manage their service. So whereas they've always struck, I've had endoscopy teams who don't understand using the endoscopy model because they're having to group things they normally wouldn't group, and it doesn't make sense for how they manage the service. So that point around flexibility of the core model is really its strength, I think.
Yeah, absolutely. Thank you for that, David. It's yeah, the part of the thinking is making sure that the tool works for you rather than you working for the tool. So it's and hopefully you'll be able to see how you might be able to apply that as we go through this. So actually, this segues really nicely into this slide, which looks at the fact that we talk about relatively simple processes. So for example, you have a request for, say, an elective service. Let's take endoscopy. What could happen then is you end up queuing, your patient queuing up as part of your waiting list, and then they get their intervention. So there'll be an appointment, be it therapeutic or diagnostic, and then they go on to the next stage of the patient pathway. You may also have simultaneously same-day requests, so unplanned activity that you might need to do. If they fall under the same capacity umbrella, so if they're all kind of coming in for endoscopy, for example, then we can actually look at that almost as a parallel part of the demand. And the question that we can look at then is, do you have enough to support both streams coming in? So as David said, you've got a lot of different options. You can have initial assessments. You can have also, this model can also be applied to things like post-op, because when we talk about requests, it's not necessarily just a referral. It could also be, say, a completed operation, and then a patient needs to come in for post-op, like something like a cataract operation, if they need to. That basically would be, your DTA would basically be your demand. And then from there, you would then have the post-op and then on to discharge, for example. So there's lots of options here in terms of how you can actually apply it. So in terms of the modeling, that's only one part of the story. David's already kind of talked about the practical aspects. I'm going to hand over to David now, because he's done a lot of work in actually putting this into action. And this is one important but only a small part of the overall process, because this is meant to support your improvement work. So over to you, David.
Yeah, so I mean, so I've spoken a lot about this in the past, and this is where I'll do a slight disjustice to the core model when I say that the most beneficial thing that you will do by conducting a comprehensive D&C using the core model is not the model itself. What you get out of it is the service team will really thoroughly understand the bottlenecks within the service just by going through this process. So when you're talking through, what type of demand is coming in from where's it captured, what is that in terms of volume, the level of variation that the service is having to see and manage. You understand how capacity is structured, what the clinic structure looks like, what the pattern is as well. So you can see the level of sort of ad hoc that's having to be brought in, and you can quantify that very clearly. Often you can see, the service is only able to manage because they have so much ad hoc capacity in place. And that really changes the conversation around not just plugging the gap, but the sort of investment that it takes to just maintain BAU at that point. So it really is about all of the information that you get as a result of just going through this exercise. And that's why some of these boxes are absolutely critical to this process. So obviously, first one is what question you're trying to answer, and that for most people is just how much demand do I have to see, and how much capacity do I have available to see that demand? And usually there's a difference between the two, but it can be often a lot more than that, and a lot more detail, and some of that I've just covered. Getting the right people involved is essential. I think one of the hardest things is trying to make that translation between modeling and sort of thinking of things in a numerical way versus how services would normally manage themselves, which is not necessarily like that. And often you need someone who, someone to kind of coordinate this process and almost provide a bit of translation. So someone who's a bit au fait can kind of know their way around that spreadsheet. It doesn't have to be in great detail, but just feel comfortable and not overwhelmed by it, which anyone can get to. It's not, it's just a case of getting familiar with the model. And then, being able to translate that to the service team, so you're able to walk them through it. It's baby steps along the way, so they sort of feel comfortable, and then ideally they're taking on the model, and it becomes a kind of a self-fulfilling thing. And you also need the links in with informatics to get hold of the data if that's where you get it from, and the clinical teams as well to ensure you're sense checking it, and you build this kind of network of people around this process, and then doesn't become reliant on you as an individual having to do the modeling. People start chasing you because they get interested and they want to see the output and they see the value in it. And obviously that links heavily to what resources are available to you to actually complete it. So a lot of that is just around data, access to information feeding into the models. All of that needs to be clear and upfront. And I would really recommend that you get a kind of sufficient level of seniority or senior buy-in to put this on the priority and say that people should be engaging with it, and that really does help facilitate things. And the rest of it is kind of sort of a bit more intuitive, really. So, do you have an achievable target for what you're trying to get to? And that's very much linked to the question you're trying to answer. You're coming up with a plan and you're following that plan and the timelines that you want to achieve them by. And then the last thing is just be curious. I'm slightly biased. I find this stuff really interesting. So it's easy for me to say that it is, it is interesting when you find this stuff out and you can quantify it. And I've had a conversation only the other day where we were modeling colposcopy, and I was talking to the service managers and the booking clerks who totally didn't get the modeling. But when you are walking them through the model and what it's saying about the service, and you can almost see that light bulb moment where they get it and they understand what it's saying, and that totally fits with the pressures they feel on the ground. And then there's just a complete switch to, seeing this is really important, that it's there to, that it's going to support me in what I want to achieve in this service, and what I want to articulate to my GM and my director of finance, and put the case forward for what we want to do in the service. So yeah, I would just say maintain that curiosity and that interest, because it's that sort of enthusiasm is really key to a lot of this.
I might just throw in a question to you, David, because I know you're saying about having an achievable target, and you've rolled this out with quite a few services. How long does it take typically to put a first iteration of the model together?
Well, it's easier for me now. So let's say when I first did this, I took at least 2 or 3 months to get from the very start to the end of something. And all of that is just getting hold of data and information. Filling in the model can take you about 10 or 20 minutes if you've got everything where it needs to be, and even that's a bit of a stretch. It could easily be done faster than that. So the time it takes to do this is all around getting the data sort of agreed, and that you're pulling the right things and it's saying the right things, and that, getting the right sort of clinic information and capacity information together, getting it sense checked. That's the stuff that's time consuming. But you can also see how this is, because it's not like a continual piece of work. You kind of send an email, you wait for it to come back. The whole time you can be getting on with other things. It's not like you just spend 2 months solidly doing this. It's just that, this invariably has to run alongside what people are doing. And I would initially give yourself that time for the first iteration, but then after that, because the data is, you already know where to get the data, you already know what to look for within that data source, the pitfalls that you've encountered the first time. So in subsequent iterations, it's much faster. So it's sort of days and weeks at that point to update. And I've even I've reiterated things within a day from start to finish before. So it just, that when you've done it once, that's the hardest bit, and then after that it's much faster.
So this slide just here looks at the different types of analytics that's out there. And I think historically we've often looked at the what happened aspect. A lot of our modeling looks at what happened last, and to try to describe what we think has actually happened. Some of this is about, and this type of modeling to support looking at what needs to change to make services work better and improve as we go. It actually requires us to move into diagnostics, predictive and prescriptive analytics. I just think, David, when you've kind of gone through the modeling process, what's been your experience in terms of how your services actually look to manage look to put together its planning? Have you seen any shifts in terms of when you're going through the modeling process? Has that helped you kind of shift your stance from being reactive to proactive?
Absolutely, yeah, hugely. So the best example of that is endoscopy, and I know people have seen me talk on things like this before, I always draw on this example, but it's the kind of program that's been going on the longest with this stuff. So historically we used to manage things how most services were managed, which is we only really did something about it when there was a problem. So when there was a waiting list or a backlog, and prior to that you just sort of assumed it was all getting along fine. And on the ground, they probably had a general feel for whether they had enough capacity or not, just because, you're starting to not be able to book patients in as quick as you might want to, or, slots are less available than they would otherwise be. And you start to see the pressures or feel the pressures there, but certainly you can't quantify that, and you wouldn't be able to articulate that into any form of kind of service development or business case. And that can kind of tick along until there is a waiting list and a backlog. And we found that it became a very significant waiting list and backlog. So if at the point that a commissioner finds out there's a problem, it's far too late. And so, you know, there was real motivation to have much more greater oversight of what was happening in endoscopy services across the whole of South East London. So we started this kind of comprehensive D&C approach with each of the units. And, you know, sort of 2 years down the line, we're at a point where it is part of an annual business planning process. So before they even come to their contracting round with their directors of finance, they are fully briefed on what they need to deliver for the year ahead, whether that's insight, so everyone's on block where we are. So you know, if is that absorbable within the sort of assumed 5% growth that we'll see within contract, or are there other discussions that need to happen? And on top of that, they're much more able to kind of facilitate in new innovations, so they can carve out physical space for things like colon capsule endoscopy, which are coming in, or transnasal, or cytosponge, those sort of things, those sort of innovations, which will in the long term free up a lot more capacity, but in the short term requires you to dedicate staff and possibly other clinic space to kind of proof of concept and get that activity built in. So we're much faster at all things now. So not least kind of teams they have much more capacity and are more flexible with that capacity because they've got that level of oversight. But it also means that new ways of working and new innovations are much easier to implement because there's that confidence that we kind of know what we need to do, what we need to deliver, and what we're likely going to have to deliver over the next 52 weeks. And then within that, we can work out what else we might want to do and what we feel comfortable carving out for other things. So yeah, so it is a bit of a, I mean, game changer is quite a strong word, but I think it has been, and I think if we hadn't done it, we would still be working in a very reactive way.
Yeah, I think if I just that was just circling where we actually want to get to in terms of our analytics, as I mentioned earlier. But if we go to the next slide here, we can see that you know, everything that David's just talked about. I feel we've jumped ahead a little bit, but you know, the core model is not an end in itself. It's about improving your understanding of your service so that you can then target specific actions that will support your improvement. And that can cover, you know, a whole range of things, from data quality and improvements that you need because you find out you haven't got the data that you need, for example, to quantify your capacity or your demand, your clinical system configuration. So certainly when I've run this in a practical environment, we found that actually our clinic codes were configured in the wrong way to be able to identify, you know, for example, particular conditions, and it needed a reassessment of how you're going to put that together. And similarly, if you're looking at pathways, quite often, I think going back to what David was saying about being a detective, sometimes if you poke something and you ask the question, well, why are we having, for example, an overly high DNA rate for a particular condition? So I worked in ophthalmology, and we did just this for one of the conditions. I think it was chalazion removals, so little lumps and bumps in the eyelids. It had a 25% DNA rate, and when we looked at it, first of all, we identified it was far too high. And when we did a bit more of a deep dive into identifying why that was the case, it turns out that they resolve spontaneously if patients are waiting for more than 4 weeks, more often than not. And so it led to a change in the booking process to make sure that only patients who could actually attend within a relatively short space of time would be put down for an outpatient procedure. So it's that kind of thing where it's not necessarily a direct output from the model itself, but it does highlight things that need to change. And this is actually one of the outcomes that you actually want from this modeling, is proactive, positive kind of changes that you can then push together. And as David said, you know, the evidence to support much longer term changes as well, so that it's actually highlighted, evidenced, and then you can actually push that forward.
And just to add another example to that, is not it doesn't always mean, you know, the output of this means asking for more or needing more capacity. So a really good example we had is we had a lot of issues within our CT pathway, and when we modelled that, what we found is because of the amount of carve out that's required to manage 2-week wait demand and on the day demand, we were finding that the routine waiting list was going up, and all of this wasn't really, we didn't really understand the dynamics of that. We just, you know, assumed, like most people would, all routines has always got a long waiting list. But When you go into the modelling, when you look at the service overall, the output was that there should be enough capacity, that there shouldn't be a waiting list. Or it should certainly be within its sustainable size. So it was very odd that we had a backlog, such a significant backlog in routines. And then through going through this exercise, we found that actually there was far too much carve out for 2-week wait and urgent for given the amount of demand that is actually being seen there. And so we could, there was, because we understood that in detail, then the team felt more comfortable reducing that carve out to be able to service the routine demand much more, in a much more efficient and timely way. Whereas if you hadn't had that understanding, if you asked a service to reduce its urgent carve out, I don't think anyone would, because they wouldn't feel safe doing it. So you need that level of detail, that level of granular understanding of what's set up to service whatever amount, and that helps you then change the service. So in that case, there wasn't a need for any more. It was just slightly changing the clinic structure and the rota and the carve out. So that was a very quick, easy win for everyone involved.
Super. So we've done a lot of talking about how you could use the model to help you with your improvement work. Let's have a little look at some of the actual innards of the model itself. So this is a screenshot from our model, and you can see, going back to what we were saying about how you can configure it, you've got different options here where you can look at, for example, looking at the number of, for example, modalities that you need to account for, and by that, this example is from a CT service where you could look at different types of CT scan, which might take different lengths of time, for example. So you could put in up to 10 of these, and that gives you the flexibility to go through different types of interventions that you might want to look at. And you can also account for planned or same-day activity, and that's some of the carve-out. So going back to what David was saying, if you need to have carve-out, you can then see how much you're actually using or you need to provide. And you can also highlight how much basically headroom you need to provide, because with any service, you need a certain amount of headroom to account for things like variability in order to have the resilience necessary to account for peaks and troughs in your demand. So this will help you quantify that in a relatively scientific way, so that you can actually go, okay, we need to have this much extra headroom. And that means that if you do have a bump in demand, then you're not going to end up with patients waiting unnecessarily. So when we're actually looking at demand coming in, and we'll kind of look at in more detail in the model itself, demand flows in quite a particular way, and we model it here. So typically when we talk about demand, it's often just the request for treatment. So it could be referrals. I mentioned completed operations or DTAs potentially. That's kind of that's the initial bulk of demand that's actually coming in. But you don't always use all of your capacity to meet all of that demand, because there's always patients, for example, that cancel ahead of time or are inappropriate referrals. So those are removals of the treatment, ROT, or early notice cancellations, where patients basically cancel ahead and say, for example, we don't need to use the slot. Those patients we can also kind of account for and remove from the patient flow. Then you have basically in purple the number of clinical slots you actually book and use. And some of that will also incorporate DNAs or short notice cancellations that need rebooking. So some patients will DNA or cancel and at such short notice that you can't reuse the slot for someone else. And the ones that aren't discharged will basically need an extra slot. So that's how we can calculate the total capacity required. And then of the patients that are seen of that lot, then you'll have a certain amount of activity, and that's what you measure at the end. And I suppose the reason I'm showing this here is because historically, when we look at capacity, we've looked at activity as a proxy for capacity. And straight away, if you look at this little flow chart, you can see that that's actually not a great measure, because there's lots of other things that start to bias what your capacity is, because your clinical capacity, what you have available or what you need to provide is actually a mix of these different values. So your demand is one thing, how much capacity you can provide, including the overhead requirements, is another thing. And then finally, the activity that you can measure at the end is a separate number altogether, and we can look at some how that's kind of entered into the model in just a second. But hopefully that makes sense to you all in terms of how patients actually flow from demand all the way to actually being treated. David, I don't know if there's anything else you want to add to that, just to check in with you.
No, I mean, I think these are really important variables to include in your modeling, and actually you'll probably all be very familiar with them and they'll all make sense. And actually, this is the whole a benefit of speaking to teams about this when you're doing the modeling is it helps build trust, because these are things they're really worried about as well, and they see it as a major impact on their ability to provide capacity and manage demand. So, as much as what Keith is probably about to show you being this slightly confusing parameters tab that can throw people off sometimes, it's one of the most important ones, because not at least does it reassure services that this modelling is taking into account these very important factors, but it also is just, it reassures everyone that you are working towards what you're supposed to be working towards in terms of measuring demand, and not the opposite way around and just looking at activity.
Thanks, David. So let's look at the parameters tab. This is basically how we account for flow, and these are numbers that you'll be putting in into the model as you go. So you can see, first of all, we've got our demand coming in, and that would basically be something coming straight off, for example, your PAS system, where you have, for example, referrals as kind of a I noted earlier as an example of what you might have if you're having a first assessment. The orange bit, and you can see I've color coded this to match. This is basically stuff that doesn't need an appointment. The purple bit is basically clinical slots that are used, and then green is where patients leave the pathway, either as having been seen and treated, or having been discharged following a non-attendance based on your access policy. So what I've certainly found when putting this into practice is that this is a really nice sense check for a lot of process issues. So I mentioned the DNA, high DNA kind of example before of patients that were coming in for a particular condition, but it's also a really nice way of looking at, for example, what your access policy is for your DNAs. So looking at this, for example, you would immediately start wondering why you discharged everyone that didn't actually turn up for their appointment, and check if that's actually an appropriate application of your attendance policy and things like that. So this often prompts quite useful conversations as you go. So once you've entered your demand, once you've entered your capacity, once you've looked at how you balance out the different aspects of how should we say, the patients kind of coming in and out of the pathway through ROT or rebookings and the like, the model basically takes that information and gives you two main outputs. One is a look at what you need to provide. So this is the required capacity. So that's adjusted for all the parameters that we just saw. And the other one is what your estimated capacity is. And that's based on looking at, for example, your clinics and how many weeks a year they're running and such like. And basically you want the cross to be somewhere in the blue bit. And that's basically all it is. If your capacity is underneath that, so if it's below it, that means you've got a gap and you need to provide more in order to keep your waiting list stable. If it's above it, then your waiting list is likely to go down over time because you've got surplus capacity potentially. This is very much almost like a risk management tool, because this doesn't necessarily mean your waiting list is going to go skyrocketing at a rate of knots. It does mean that there's a risk that you're not going to be able to provide enough capacity on a week-on-week basis to see all the patients that are actually coming in. The second one is looking at, as I mentioned right at the start, what your sustainable waiting list size is versus what your current waiting list position is. And if this is too high, so if this is significantly above your waiting list position, sustainable waiting list size, then once again, it's a risk assessment. There's a risk that your patients are waiting too long, or they may end up waiting too long. And the outputs of this basically need to be married up to what's actually happening on the ground. And that's actually the most important thing. You can get lots of data, but the data is not always correct, or it might not be always set up in the right way. So this goes back to what David was saying about, it takes a little bit of time going back and forth checking, making sure that this is operationally validated. And once you've got that, then you've got something that can be used as a really strong evidence basis. And the history of all the work that you've done to check this is actually part of that story about saying, yes, this is reliable data. And then that basically feeds into a narrative that you can then use to talk about what needs to be done next. I've rapided it on quite a bit. David, is there anything that you'd like to add to this?
Yeah, I just was going to draw attention to the point you made earlier about how the model incorporates sort of planned and same day within this summary tab as well. So you can probably see right at the bottom left, there's this box for reserved capacity. So this comes back to the point that Keith was making earlier, that you can structure these models to take account of any demand that is coming on the same day, or any kind of planned, so like surveillance and follow-up work that you need to incorporate into you need to make sure that capacity is reserved for that to maintain your ability to meet that level of demand on top of what's coming through electively. So the models do that really well, and it's really useful that it's in this summary tab, because you can see sort of how much you're kind of losing to that, although it's not obviously being lost. But it just helps you see kind of the whole this summary picture for the whole service, and it's sort of it's allowing you to show everything all in one place, including that planned and same day work.
Lovely. So this final bit is just a heads up about updates that we actually are continuing to provide to our models. So with COVID, that's obviously changed a lot of things in terms of how services are looking at how they're planning and things like that, and also about the demand that's come in, because, for example, there's been a big gap where GPs weren't referring anywhere near as often, for example. And so we included functions where we could look at issues just like this, where demand basically isn't reflective of the genuine demand out there, because just because GPs aren't referring patients in doesn't mean that necessarily they're not getting ill with a particular condition, for example. So we basically added these sort of little extras in there. I suppose this speaks to a more general point about these models are there to help you kind of just structure how you're actually asking questions about your service. We provide updates, but also if even if kind of you've got something that you're not entirely sure if it fits within the confines of this model, we'll see that there's other types available. What's most important is you're actually thinking about the process of how patients are coming in, what the pathways look like, and part of our role is to support you in actually making tools or using these tools in ways that will actually best reflect how your service operates. And
also, I think, Keith, it adds to another side of using these models isn't just to model kind of the actual operating model of the service itself, is you can use them to look at, you can kind of scenario model as well. So this is a really good example of, functionality that's been specifically put in place to look at that, but you can actually do it in a really basic way. So if you've looked at, you've got you've got your demand data in there, and you've got your capacity data, you've got like all your parameters sorted, and it gives you your summary picture. And you can start asking questions like, well, what if we reduced our DNA rate down to 4%? What does that do to the balance between demand and capacity? Or what if we ran Saturday clinics? What would that do? Or what if we moved everyone to, having, really reliable cross cover, and we were all doing 48 weeks per year? And, this is the stuff that you can really start teasing out. Where's the biggest bang for your buck? Where are we going to invest the most resource in terms of whatever service development we're going to plan, because that's what will deliver the greater amount of capacity in the long run. So you can actually use the models as is to try and scenario plan, and you can create different models for different scenarios. And I think there's a lot of functionality even without dedicated functionality like this to kind of model different scenarios and impacts.
Yeah, that reminds me, in fact, just this very morning, we spoke to a trust that were using several different views of their capacity, and it's something that's actually really useful, is looking at, for example, and especially in current climes with COVID causing all sorts of staffing issues, they were looking at their in-post versus their establishment and trying to quantify what that gap was versus the gap between demand and what they should be able to provide. So you can see here, you could almost have three models here what you have right now, what you should be having, and what you need to have in the future. These all give you quite a few different ways of looking at your information, so you can actually have an informed conversation about what you need to do next, basically. So hopefully this demonstration is giving you some idea of how the core model might be able to support your work. Fundamentally, and I'm allowed to say this because I made the tool, I guess, this is just an Excel sheet. And its main use is as a framework, really, to structure how you want to apply your improvement methods to your service. It will give you some evidence-based quantification of all sorts of metrics around demand, around capacity, and one of the things that we ideally would like it to be used for is as a business as usual, as David said, business as usual as part of your operational management. So this is not something that you do once a year, but you do it on a continual, ongoing basis anytime you're making a significant change or considering a significant change to how you're actually going to be implementing your SOPs and things like that. And actually, as a model, this is kind of almost a starter kit. We have worked with a lot of trusts that have taken it and wanted to embed things into their own data warehouse or their own business intelligence software. So it's almost a stepping stone. Once you've got this, once you've got the processes, and that's a really difficult, most time-consuming bit. Once you've got the processes and the knowledge in place, then actually getting a developer in to put something more advanced together for you that might be more automated, for example, that's well within kind of the capabilities once you actually know what you need to develop. David, I don't know if there's anything you want to add to that.
Yeah, just very quickly. I think so. There's one of the benefits of this, as we've said, is not necessarily just the creating the model itself, although that helps. And it's, for me, some of the best things have been, understanding how you should measure demand, and it shouldn't be an average, and there's reasons why it shouldn't be an average, and it shouldn't just be the total for the month or the total for the year, because you're never going to be able to sustainably plan at that point. So there's the fundamental kind of methodologies used within the core model, like accounting for variation and measuring as a percentile, taking account of different parameters and variables like DNAs and ROT, measuring capacity over an averaged over 52 weeks rather than just a solid 52-week block. So there are these kind of modeling methodologies that are really useful to kind of just, if they become BAU and they just become part of BA, sort of how everyone talks about demand, how everyone talks about, how we should measure demand, how we should be talking about capacity, that is a huge help, because, I spend a lot of time talking to teams around why you shouldn't plan your 2-week rate capacity on an average, and it's not taking account of variation. And actually that's really important for cancer, because you do see a huge amount of variation. So you're setting yourself up to fail at that point, and we can help make sure that business cases are, much more robust and much more likely to deliver a success. So I think there's something about, there's the modeling itself, but there's also the language and the methodological approaches you use, having a good, that the system and the people you work with have a good understanding of that, and they see the value in it, is a really important part of doing this work.
And this segues really nicely into, we have a host of case studies looking at the model actually being deployed in the wild in various applications, and you can see just, I suppose this is the theme. It's about thinking how the model can actually be used to best represent the service that you are looking at. So it's going from a quite strategic view where you're looking at assurance that you've got something in place, for example, to quite specific areas about service redesign, or looking at specific pathways, or looking, in fact, at subspecialty levels, or looking at, examining the right granularity modeling. There's lots of different ways that this can actually be applied. It's very much about kind of thinking what's your needs and how this can actually work for you. On that note, there's a range of different types of models we do have. So those of you who've seen our earlier webinars. There's the caseload model. We've also got the urgent response model. This basically looks at response in terms of what kind of time frame you're looking at. So your non-elective work might be within response time within hours, for example. You've got days and weeks for the caseload model and core model, and at the much more strategic end, we've got system dynamics that can look ahead in terms of years. And in terms of the complexity of the skill mix or the capacity that you need to put in, you can see that the core model is kind of the straightforward one to work with, and then you can basically stack up as you go into much more significant levels of complexity when you're looking at individual skill mixes and such like. If you want more information on all this, we've got our case studies available on our Future NHS website, and on our main webpage we also have walkthroughs of the models that go into quite a lot of technical detail about how you actually use all the different parts of it. So everything that you've heard today, but in a bit more detail.